Yusri, can we finish with 10 minutes or we have to extend it to 20 minutes? What do you think? السلام عليكم ورحمة الله. طيب احنا we do have يعني few cases كده with different scenarios. The first case, please. So younger than 65 years old, fit, high risk cytogenetics, first relapse less than 1 year post autologous stem cell transplantation during lenalidomide maintenance. Is there any volunteer can tell us exactly what should we do with this patient from the audience? Any volunteer? Yes or no?
Doctors, feel free to unmute yourself.
No, you cannot hear me?
I can hear you, doctor.
What about the audience? Are they hearing me?
Please, everyone, if you have any question or if you would like to discuss the case with Dr. Fahad, please unmute yourself.
Is there any volunteer to discuss this case and to tell us what he or she will do with this case? 65, younger than 65 years old, fit, high-risk cytogenetics, first relapse less than 1 year post autologous stem cell transplantation during lenalidomide maintenance. Is there any volunteer or no? Yes or no? طيب, I will start. Are you hearing me? Are you hearing me?
Yes. Yes.
Okay. Okay.
Yes,
Good. Let us just think about this scenario. He is a young patient. He is fit. He was diagnosed with high-risk cytogenetic. What will be the first treatment for this patient? Of course, induction treatment. But because he is high-risk cytogenetic, we have to give him the best induction we do have nowadays. For example, carfilzomib, lenalidomide, and dexamethasone. Not only this, but because he is a high risk, it has been recommended that tandem transplantation is good for those patients because they are high risk. They are going to relapse if you are not treating them very well. Even though if you give the first transplantation followed by tandem transplantation, you have to think about what's the maintenance should be for this patient. Lenalidomide alone is not enough for this group, high-risk cytogenetic. You have to give him actually a combination between IMiDs in form of lenalidomide and proteasome inhibitor in form of Velcade as a maintenance for a long time. You see, now we have to live with this scenario. He's younger than 65, fit, high risk, first relapse less than 1 year post autologous stem cell transplantation after the lenalidomide use. So we have to think about this patient that there is no chance to take him for a second transplantation because he has relapsed early enough, and second transplantation not going to benefit him. So what the options of the treatment at this stage? Yes, we have to choose the best combination because he's young, he's fit. This is the best, and the best treatment for him at this stage really, the candor combos like daratumumab, carfilzomib, and dexamethasone. This combination should be given to this patient, not other medications, because already he exposed to lenalidomide, so try to avoid lenalidomide. So give him the other combination, carfilzomib, monoclonal antibodies with dexamethasone. For how long this patient should continue on these medications. As we mentioned earlier that he is not fit, or he is not eligible actually for a second transplantation. We have to continue with this combination with him until side effects or disease progression. As long as he is tolerating the medications, we have to continue because this patient is a high risk patient. He will relapse at any time, even if he is on good medications. So we have to continue with him, carfilzomib, daratumumab, dexamethasone, as long as he's tolerating that, as long as there is no disease progression. So at one stage, for example, he relapsed, even though while he is on this combos, carfilzomib and dexamethasone and monoclonal antibodies in form of daratumumab. What can we do with this patient? Here might be, because he's a high-risk patient, he is young, you have to think about other alternatives. Yes, new medications like pomalidomide, like for example, other medications, other monoclonal antibodies, like for example, CAR T-cell. He might be eligible for CAR T-cell therapy. Yes, as I mentioned before, CAR T-cell therapy is not yet approved in multiple myeloma, but trials are going on. So he can be enrolled in a good trial with CAR T-cell or not. If there is no CAR T-cell trials, we can include him in the new medications like the bispecific or trispecific monoclonal antibodies trials, because the results are so far encouraging. Okay? Any comments or any question about this case? So next slide, please. So what should, okay, you went to the next case. Okay, the next case actually, he's younger than 70 years old, unfit. So he might be heart problem or chest problem or kidney problems, and no previous autologous stem cell transplantation for him. But when he was treated with VMP therapy, he got his remission for 20 months, then he relapsed. What can we do with this patient? Any volunteer? Because he relapsed within 20 months or after the 20 months, I think at this stage, we have to avoid whatever medications was given to him before. So he was given proteasome inhibitor, melphalan, and prednisone. So we do have really more medications really, and effective medications in those patients. For example, IMiDs like lenalidomide is a very good, especially when it is combined with dexamethasone. Probably this is the right for him to treat him with Revlimid and dexamethasone. If you are really thinking about triplet, you might add the oral proteasome inhibitor in form of oxazomib. Otherwise, lenalidomide, dexamethasone is a very good for this patient. And for how long? Give him until he will have side effects or disease or progression. Okay? Having we mentioned that, still, monoclonal antibodies can be given to those patients unfit according to their unfitness, because monoclonal antibodies, especially anti-CD38, whether daratumumab or the new one isatuximab, can be given as a monotherapy only, without any cortisone, without any other medications. Monotherapy can be effective in those patients. So we have two choices actually here, either to give him Revlimid dexamethasone or to give him really monoclonal daratumumab. Or might be, if you are thinking to give him more and his unfitness is not that bad, you can give him triplet with adding to Revlimid dexamethasone isatuximab, which is the proteasome inhibitor in oral form. Okay. Any opinion or any? Okay, next slide, please. So what should the treatment goal be for this patient? Of course, the goal here is really remission and deep remission, really, to give the patient as much benefit as you can give. And by the medications or by the combinations we mentioned, probably he is going to achieve this goal. Next slide, please. So what would you prefer regimens be for a patient who relapses after VMP, and why? Whether doublet, yes, we prefer doublet, as I mentioned, Revlimid and dexamethasone. Bortezomib-based, no, actually, based on bortezomib-based usually means Velcade. Velcade should be avoided here. Might be a second generation like carfilzomib, but in those patients who are unfit, carfilzomib, 15% of them, they will have, of the patient, they will have cardiac toxicity. So it is better to avoid it, you see. So we can avoid bortezomib-based triplet, is not working. Lenalidomide, dexamethasone-based triplet, probably this is a good one, lenalidomide, and this is probably the best choice here. Monoclonal antibodies-based combination, whether based or, as we mentioned, monotherapy with monoclonal antibodies, anti-CD38 in form of daratumumab, can be given to this patient. Next slide, please. Okay, would you change your strategy if the patient had relapsed later, 3 years? Might be yes, and how? Actually, transplantation is not an option in this patient, but because he is younger than 70 years, he might go for the new trials with the CAR T-cell therapy or the new bispecific or trispecific monoclonal antibodies. So to take this patient for trials. Okay, next one. This is case 3. Case 3, more than 80 years old, frail, dependent upon family, no autologous stem cell transplantation, and he relapsed 12 months after the first line VMP or RD. Okay, so here really the option is really minimized because he is already given VMP or given RD. If he was given VMP alone, you can give him RD, and keep in mind that dexamethasone dose should be reduced. Instead of to give him 40 milligram weekly, you can give him 20 weekly, okay? Revlimid, you can play with the dose really, not necessarily to be 25 for 21 days or 14 days. You can decrease it to 15 to 10 milligram, because here you are dealing with elderly patients. So you have to keep in mind that those patients are really prone to develop side effects from the medications. So when you are treating patients with multiple myeloma, think about the side effects and to benefit the patient rather than to harm the patient, okay? So if the patient was given initially RD and he relapsed, you can try with him Velcade, methylprednisolone, still good combination and can be well tolerable in elderly patient. Okay. Any questions or any opinion about what I mentioned? Okay, next slide. See what the next question. What should the treatment goal be for this patient? The goal here is not really, we cannot achieve actually deep remission or complete remission, but this is a sort of some palliative for this patient, elderly patient, you see, because we would like to avoid side effects. Okay, next question, please. What would your preferred regimen be for an elderly, frail patient who relapsed after VMB, and after that he relapsed after RD. So the choices has gone, which is these are the best treatment for those elderly patients. And why? Doublet, very difficult really to give him, because already he relapsed after dexamethasone, he relapsed after prednisone. So you can choose here really monotherapy, monoclonal antibodies, and only mono, not in combination. Bortezomib-based triplet, already he relapsed on Velcade, so it is better to avoid it. And if you are thinking about carfilzomib, as we mentioned before, carfilzomib has cardiac toxicities and should be avoided in elderly patients. So it is not an option, this bortezomib-based triplet, not option for in this scenario. IMiD-based triplet, you have already tried RD, but here with IMiD, you can try, for example, pomalidomide, and to observe the patient carefully. The other options, monoclonal antibody-based combination, I will avoid it here, but I will give the patient really monotherapy with anti-CD38 daratumumab. Next one.
Assalamu alaikum, Doctor. Can I ask a question, please?
Yes, please. Yes.
I'm Sarah. Doctor, regarding
أهلا يا سارة, حياك الله. تفضل يا أختي.
Doctor, regarding fit patients failed 2 lines of therapy. Before shifting him to CAR T cell, can we use elotuzumab or selinexor? And is it better than CAR T cell or the same?
I think CAR T cells so far giving really encouraging result, but however, it is not yet approved. You see, while there are still other medications, especially monoclonal, bispecific or trispecific, still going on under trials. Other medications, very difficult to try it in those elderly patient. But you are asking about fit patient. Definitely you can try it. In fit patient, after 2 lines of treatment, you can try it. I think no objection about that.
Thank you.
Any other question? I think at this stage we have to stop here, because we are passing the time now, 7 minutes after 11 o'clock, and we promised 11 o'clock we have to conclude our meeting.